Hi, my name's Ben. I'm a hand surgeon and researcher in Oxford, and I've put together this talk towards better wrist injury pathways, mainly aimed at clinicians, but obviously anyone is welcome to listen. Thanks. So I wanted to do this talk really to summarise what we know and put that in context with current wrist injury pathways, explaining the implications of what different pathways mean for people with wrist injuries and the clinicians. We know wrist injuries are a big problem, and a large number of patients end up being assessed at an emergency department or at a minor injuries unit, having pain, tenderness around the scaphoid on the thumb side of the wrist, and then having x-rays which are normal. It's about 70,000 people every year who form this group of people, and sometimes this is described as people with suspected scaphoid fractures. The importance in not missing the subtle scaphoid fractures, these ones that you can't pick up on x-ray, is that some of them will go on to not heal, and this is often painful, gives people problems using their wrist, and it becomes harder and harder to treat over time and can result in significant arthritis of the wrist joint. There are a wide variety of pathways used in the UK. We've written about this. You can use early cross-sectional imaging, so MRI or CT. Some pathways discharge people early without cross-sectional imaging, and then there are pathways which bring people back for further clinical assessment and further imaging at a later date. There are lots of pros and cons of these different pathways, but we do have some high quality evidence in this area. We know that MRI is by far the best investigation for picking up scaphoid fractures. It's practically 100% sensitive at picking up scaphoid fractures. The CT is the next best and picks up around 80 to 90% of scaphoid fractures, meaning it will miss around 10 to 20%. We know from particularly the recent SMART trial that patients prefer early imaging with MRI because they get a clear diagnosis and they can be treated promptly. You get better patient experience, better patient satisfaction with early MRI. We also know early MRI is significantly cheaper because you don't have the increased costs of bringing people back for repeat assessments, repeat x-rays, and then cross-sectional imaging later, which ends up being much more expensive, almost £300 per patient at 6 months. So to try and bring it to life for you and make it a bit easier to understand, here's a diagram, first of a few, with these patient icons to represent different patients presenting over a year. So for the average small to medium sized UK hospital, you're going to have about 63 scaphoid fractures every year. The yellow icons there, 38 of them, represent the scaphoid fractures that are obvious on an x-ray. The black icons below, 200 of them, represent the patients who come with pain and tenderness around the scaphoid and have normal x-rays. So over the year in this mythical hospital, we have around 200 patients who have pain in the wrist after trauma, they have tenderness around the scaphoid, and they have normal x-rays. And we don't know which ones have a scaphoid fracture. From our previous work, we know around 25 of them are going to have a scaphoid fracture. If we have a pathway where these patients are all referred for an early MRI scan, then we'll pick up all 25 of these so-called occult scaphoid fractures. That means that these patients can be treated promptly, generally with a cast to immobilize the wrist, and this will reduce the chance of them getting a scaphoid that doesn't heal. It's pretty logical and clear that if you don't get people in a cast relatively soon and allow them to move the wrist in and out of a splint, then you're going to increase the risk of this scaphoid not healing. We know that less stability is a clear cause of delayed and non-unions. The great advantage of MRI is that you can confidently say to the patients what their diagnosis is, and you can confidently tell them they don't have a scaphoid fracture if the MRI scan is negative. And this is great because you can get the majority of patients, around probably 60-70% at least from our work, we've shown this, get them moving straight away and get them back to activities as pain allows, because the scan is often quite reassuring. This is obviously great for patients, and if you end up being sent away and not having a diagnosis early on and having pain, it's not a pleasant situation to be in as a patient. You don't know, you've got soreness, how much should you do? The uncertainty is going to have a psychological impact. The pain, how far to push into it, can you get back to work, can you get back to sports and hobbies? It's just a very tricky situation to be in. So what happens if you use early CT and not MRI? Well, you'll pick up the majority of the scaphoid fractures. You'll pick up about 21 of the 25. You can see 21 yellow icons here, the ones that have been picked up, and the 4 red icons, the ones you haven't picked up. The problem is the ones you haven't picked up, you don't know which patients those are. You'll have about 30% of your CT scans will show an abnormality, and you can then be fairly confident in your management with those patients. The problem is for the other 70%, you don't know they don't have a scaphoid fracture, so you can't be as confident in your management for those patients who still have pain. And I think this is the big negative of CT over MRI. So if you have a pathway which discharges everyone who has pain and normal x-rays, then if you give the advice that if the wrist remains painful they should come back, you know that you've got, within those 200 patients of your year, you've got 25 scaphoid fractures that you won't have picked up. There's a massive unknown in terms of the evidence here, because we don't know if all the patients will come back who've got a fracture, because some of them may be fairly comfortable early on and may settle, and we don't necessarily know that the ones who settle aren't the ones with a scaphoid fracture. There may be some scaphoid fractures that settle initially but then don't heal. There's also the problem for all the patients here is if they've got a bit of a niggly wrist, when should they come back? What time point? How sore should it be? We know wrist sprains take a few weeks to settle. What's normal? What's abnormal? What constitutes one that's worrying and one that's not? It puts a lot of onus on the patient, and it's a lot of uncertainty for the patient as well, because they don't have a diagnosis, but we know that over 10% of them have got a scaphoid fracture. And the problem is that we've got 25 scaphoid fractures here that aren't being immobilized. They're going to be using splints, some of them are going to be moving the wrist, maybe doing too much, and they're going to be increasing their risk of developing a scaphoid that doesn't heal, which is going to be potentially far more problematic to deal with. So you can see that this type of pathway with immediate discharge and advice does have significant problems. So another type of pathway is the delayed MRI, and that involves the 200 patients. You bring them all back at around a week or two down the line, reassess them clinically, sometimes with an x-ray as well, and then you refer all those with persistent pain and tenderness for an MRI scan. Roughly, I've simplified this for the purposes of the diagram, but 50% or so will still have some pain and tenderness and will then have an MRI scan. And assuming all the scaphoid fractures are within the painful group, which may not be a correct assumption, MRI will probably pick them all up. And then you can be confident in telling the people with a normal MRI scan that they don't have a scaphoid fracture. The problem potentially with this pathway is that some patients who have settled in terms of pain and tenderness may actually have a scaphoid fracture. And this group that we haven't MRI scanned, so maybe about 100 patients, there may be the odd scaphoid fracture lurking within that group. It'll obviously be a very low rate of scaphoid fracture within this group, but that's something to consider about this type of pathway. Plus, the big negative of this pathway is it's quite expensive because it costs a lot of money to bring people back for clinical assessment. It costs over double the amount of an MRI scan to bring someone back just for clinical assessment and x-rays. And then when you throw in the cost of a scan on top of that, you're looking at probably triple the cost of an MRI scan just for one patient coming back, having assessment, x-rays, and then a delayed MRI scan. So it's a very expensive pathway compared to early MRI. Again, if we use delayed CT scans at around 1 to 2 weeks, so we bring all 200 patients back for clinical assessment, which is obviously expensive, we know that CT is going to pick up around 80% of the scaphoid fractures here. So here you can see the yellow icons, that's the top group is the ones that have a CT scan. We'll probably pick up around 21 of the 25 fractures, assuming there are no fractures in the pain-free group. Again, the downside of CT is if you've got a normal CT scan at this stage, which a large proportion of people will, you can't be confident that they don't have a scaphoid fracture because we know CT has missed around 20% of them. And that's again the same point I made earlier, but the big weakness of CT over MRI. And here's what might be the case, hypothetically, if some of the patients who don't have significant pain and tenderness are discharged without imaging. You might get the odd scaphoid fracture that doesn't get imaged and that then presents later. But there really isn't evidence to know how big this potential problem is. And this diagram shows you the pathway involving x-rays at 1 to 2 weeks instead of a CT or MRI scan. You can see this is just an estimate because there's not great evidence to know how many you're actually going to pick up with x-ray. It's probably around 20%, being generous to x-ray. So you can see 5 yellow icons. We're picking up about 5 of those scaphoid fractures, 5 of the 25, and then you've got the 20 red icons there, and you just don't know who those scaphoid fractures are. And that's why an x-ray based pathway alone is generally not really used much in the UK, because you're going to have people with pain persisting and you simply don't know which of them have scaphoid fractures. So you either over-treat them all with casts or you get them moving, but then the problem is the patients don't know. It's not a great experience for the patient. They're going to be trying to get their wrist moving when they don't know what the diagnosis is. They're not going to know how much they can do. Do they push into pain? Can they go back to work, their hobbies, their sports, etc.? It's just not a great pathway. So this table aims to summarise the different pathways and what are the implications of those different pathways that I've explained over previous slides. So you can see the pathways are represented by the different columns. You have early MRI, then early CT, early discharge, then delayed MRI, delayed CT, and delayed X-rays. The rows represent different things, so you've got the rate of detecting occult scaphoid fractures, the first row, then you've got the confident diagnosis proportion in the second row, then the third row is the proportion of your occult scaphoids that will receive delayed treatment, and then the next row is the number of delayed treatment scaphoid fractures that will likely develop a delayed union, so won't heal. And then the final row is an estimate how many delayed unions will be related to delayed treatment in the UK overall if this pathway was employed around the whole UK. So I think the most important thing to focus on is the fact that MRI gives you a confident diagnosis. And the implications of this are that obviously you can immobilise your scaphoid fractures and pick them all up, but the key is that if someone doesn't have a scaphoid fracture on their MRI, you can be confident to tell them they don't. In the vast majority of patients, obviously some patients have other diagnoses that require immobilisation or rest, but the vast majority of patients don't, and in those patients you can confidently get them back to activity, get them moving their wrist. It's great, therefore, in terms of the patient satisfaction and patient experience, and it's fantastic because it detects all your occult scaphoid fractures. The only real downside of MRI is that you do overtreat a very small number of patients who have what you think may be a fracture but might just be bone bruising. And this isn't a big issue, but it does mean a small number of patients, maybe 5 to 10 a year, will get cast treatment. But I think it's a price worth paying given the benefits for the vast majority. The problem obviously therefore with CT is you just don't get a confident diagnosis because you know you're missing around 20% of the occult scaphoid fractures, and that means that people who have normal CT scan and ongoing pain, you just can't be sure they don't have a scaphoid fracture, so you can't confidently tell them to crack on, get moving the wrist, get back to things, and that's a real disadvantage of CT. And obviously X-ray is even poorer than CT because you don't pick up very many occults at all with just an X-ray based pathway early on. A big take home from this table is that the number of delayed unions you're going to get from the occult group in your average hospital is very, very small. They will happen, and if you do big enough studies you'll pick up the numbers, but for your average hospital, even if you just discharge them all and don't follow them up or even see any of them again, you're only going to get on average about one delayed union that's treated in a delayed fashion with the pathway. So this has big implications for researching things and claims of proving safety, because you actually need huge numbers to prove safety of a pathway if you're going to look at the numbers of delayed union scaphoid as an outcome. And this is a big problem with X-ray based pathways. Patients will have persistent pain, there'll be the uncertainty, and you just don't know what's going on with their wrist, and you don't know where those 25 occult scaphoid fractures are. And over the UK, X-ray based pathways, you're going to miss a lot of occult fractures, and that will result in hundreds of delayed unions if everyone used X-ray based pathways. So overall, it's clear that early MRI has many proven advantages. You can be confident with your diagnosis and management, you get better patient experience, you pick up your occult scaphoids, and it saves hospitals significant amounts of money. Early CT is definitely next best, but it's certainly inferior to MRI in terms of the patient experience, picking up occults, and cost effectiveness. Pathways without cross-sectional imaging, I think, have huge flaws. Just in terms of the patient experience, you don't know what's happened to your wrist. A large proportion of patients will have persistent symptoms. You follow them up and then you image them later. That's going to be costly. Even if it's only around 30% of patients that come back for cross-sectional imaging, you're still then spending more than an early MRI-based pathway, and you're potentially going to have some delayed unions within the group that you don't follow up. Also, all the patients with persistent pain who you follow up are then getting significantly delayed treatment, and your occult scaphoids that you may eventually pick up, most of them, but still they're going to be mobilizing their wrists, they're going to be in a removable splint, they're not going to be cast or mobilized straight away. So there's huge flaws with discharging people after just an x-ray. I hope this talk's given you some food for thought in terms of what the way forward here is in terms of wrist injury pathways. Thanks a lot for listening, and I hope that's made things somewhat clearer. Here are the references I've used for this talk. Obviously, I've had to make some estimates in terms of rates of non-union, and there are obviously some gaps in the evidence base, so I've had to put in a bit of guesswork here and there to try and make things as clear as I possibly could. And obviously you can see when I've modelled the pathways there that I've given you sometimes two alternatives just to make clear that there are some significant uncertainties and unknowns in terms of the evidence base.